started started your timer and here is your question.
Yes.
Right. So if you have read and understood, considering
Yes.
its surgical pathology station, kindly tell me what are the differential diagnoses that you will consider for this patient?
Okay, ma'am. My differential diagnosis in this case is a basal cell carcinoma, and I also consider a squamous cell carcinoma, tuberculosis, and seborrheic keratitis, actinic keratitis.
Can you please tell me how would you differentiate if the carcinoma or the skin lesion is squamous cell carcinoma or the basal cell carcinoma?
Okay. In basal cell carcinoma, there is most commonly occurs in age like most common in more than 40 years, and in squamous cell carcinoma, it may occurs more than 40 years or older people also, and in I see in the ulcer that look in squamous cell carcinoma is maybe irregular border and bleeding on touch, and maybe there is a hyperkeratitic lesion. And in basal cell carcinoma, it is a everted roll is ulcer and central based with a granulation tissue, and it
Okay.
look like shiny.
Right.
Yes, ma'am.
Thank you. Can you please help me and explain the lesion? This lady has this patient, this person has this lesion here on the side of the nose. Can you explain what you are looking at, please?
Here is I looked at the ulcer on the ala of the nose. It is a central ulcer present with telangiectasia with and rolled edge.
There are no rolling. What is this crest in the middle? Okay. Can you
Ma'am,
please?
there is granulation. Yes.
Yes, please. Sorry. Continue, please.
Granulation tissue on the base.
Yes. Okay. Right. Can you please tell me how would you confirm the diagnosis? I asked you the differences, but you first should have told me that with the biopsy or the excision, or how would you confirm?
To confirm my diagnosis, I need to excision of the biopsy.
Yes.
And do histopathology and also immunohistochemistry.
Considering this lesion on the side of the nose, how much depth would you take? What would be the margins?
I in basal cell carcinoma, I try to take a step margin at least 4 millimeter of margin should be take. And
how?
depth
Yes,
I
excision.
measured.
Yes, please. How excision or the margins would differ if you knew that the patient has squamous cell carcinoma?
Ma'am, it will do select a margin by frozen shock section or Mohs surgery to save margin, cut the save margin.
Can you tell me how the skin carcinoma spreads?
Okay. Most basal cell carcinoma and both. I say both, ma'am.
Yes, as a general,
Yes.
tell me
Yes.
how the
Okay, it may be
spread.
spread in locally in basal cell carcinoma. It is spread locally by it is a destructive tumor, and it's slow progressive. And in squamous cell carcinoma, it may spread in lymphatic invasion or
Okay,
mainly
can
lymphatic
you
by growth.
tell me
Yes.
the steps or the 5 major steps how invasion or its infiltration takes place and
Okay,
like this?
ma'am. First of all, local expansion of the tumor, and it invaded the lymphatic or blood vessels. Then it go to the circulation, and
Okay,
in circulation, it go to, extract to the capillary bed in secondary site, and it growth in the secondary site
yes.
as a
Can
malignant
you
tumor.
please tell me, yes, can you please tell me what are the treatment alternatives that you can offer to the patient, or what are the treatment options?
Okay, a treatment option is usually a surgical treatment and topical in basal cell carcinoma, surgical treatment, topical treatment, or radiotherapy. In surgical treatment, I will proceed like electrodissection and cautery, and just escaping the tumor and stop the bleeding by cautery. And also, if it is a large tumor, then I will cut it primarily, excision it primarily, and use some graft or fluff, or say it is a small, then I will wait for secondary in healing intention. And also, we use some cryotherapy. In here we use nitrogen gas, but we cannot take here biopsy. And also we can identify the safe margin by most microsurgery. And in topical, we can use the photodynamic therapy, and also some topical agent like fluorouracil and immunoquimab, 5% immunoquimab.
After you have excised the lesion, patient has a defect in his or her nose, as you can see. How would you cover, or what measures would you offer to the
Okay,
patient
I
to
will
fix
I will
the
do the
gap?
yeah, I will do the local flap, like a pedicle flap.
Okay,
And if it is a big, then I will take some graft from another side, like thigh.
okay. Just suppose patient comes to you with a non-healing graft, or there is infection in the graft. What measures would you do, or what advice would you give to the patient?
Okay, it is maybe due to infection, so I take some sample for culture and sensitivity to identify the organism, and I
Good.
give some empirical antibiotic according to the test protocol,
Yes.
and
And
wait for culture sensitivity.
yes.
And if his wound is infected, then I will do debridement, and wait for secondary intention of healing. And
Okay.
I cover the regular dressing, and cover
Just
antibiotic, and wait for
suppose blood culture report comes back and patient is MRCS positive. What would be your next step of management?
Okay, in this patient, if no abscess, if abscess, then I will go for incision drainage. If no abscess and wound is infected, and I will debride and regular dressing, and give some antibiotic, like and if outpatient, that I suggest clindamycin and tetracycline, and amoxicillin, or broad-spectrum like linezolid. And if and I also give some preparation, say that it is it is spreading, so take well septic measurement always. And if inpatient, I will inform the infective control team of the test. And I also use some antibiotic like vancomycin or linezolid or clindamycin. And I also inform the staff about that, and will shift the patient if single room available, or side of the ward room bed available. And I also handle the patient with all safety precaution, and should be decompensated all reusable instrument that used to the another patient should be decontaminated. And I also already said that I also inform the laundry to it clean the all linen with just protocol in MRSA positive. And also remove all waste product in yellow bin.
Okay, for
And
how long would you give antibiotic?
around 7 to 14 days according
Okay.
to an infection.
Yes, just add one thing according to your NHS trust policy or
Yes,
yeah.
yes, ma'am.
Okay, good. Right, time is finished. Just tell me, please, why have you chosen this lesion to be basal cell carcinoma and not squamous cell carcinoma?
Ma'am, first of all, is the size, and there is a telangiectasia on the
There.
basis granulation tissue, and also look like pearly plaque like.
Sorry,
This is a squamous carcinoma,
squamous. Yes.
not basal.
Sorry, things are opening. This is a red patch and there is scaly and it's irregular borders and
Yes, ma'am. I was
it's not
confused, but there's a bumpy also.
bump means when you come across something like once you stuck something. It's English word.
Yes,
There's
ma'am.
no bumpy thing. Purely white or purely skin lesion, that is different. But this was squamous cell carcinoma. So
Yes,
if
ma'am.
you mention if it was basal cell carcinoma, so it would have been mentioned in the stem.
Yes, ma'am.
So if you answer everything based on basal cell carcinoma, so if your initial diagnosis is wrong, everything goes wrong because you'll tell the management and everything according to
Yes,
your
ma'am.
diagnosis, right? And here is your question. Right, so if you have read and understood considering the QC taking station, kindly begin.
Hi, I'm Dr. Mo, one of the certificate candidates here. So how can I help you? Sorry, may I confirm your name and age, please?
Mr. Saidur Rahman, 50 years.
Sorry, I didn't hear your name.
Mr. Saidur Rahman, 50 years.
Sadi. Yeah, Mr. Sadi. Yeah, so how can I help you today?
Okay, doctor, I have some pain in the chest and also difficult in breath for 4 weeks. So I come to the
Oh,
hospital.
I'm really sorry about that. Are you in pain at the moment? Do you need any analgesics or painkillers for your pain?
No, it's bearable, no problem. I can
Okay,
continue.
so is that okay to proceed this conversation?
Sure.
Okay, so let's talk about the pain. So when did this start?
It's about 4 weeks. It's not severe, but last 2 days it is severe.
Oh, I see. So how did you notice that?
Sorry.
What were you doing when you first started that pain?
I was staying in my home, and suddenly I developed some chest pain. Also, I have some pain on my leg.
Okay. So was it silent or gradual?
Yes, it start gradually.
So what is the character of the pain? Is that crushing or dull aching or stabbing?
It is like a cramping pain on my leg and stabbing on my chest.
Okay. And for the pain in your chest, is that in the center of your chest or on the sides?
Like in left side mainly.
And the pain, does the pain move to any part of your body apart from
No,
chest and leg?
It's not moving.
Okay. And so what makes your chest pain better? What makes you feel better?
Sorry, I cannot hear.
So what makes you feel better?
When I was take rest, it will be reduced.
When you do?
When I take rest.
Okay. Is there anything that makes you feel worse?
Okay. When I walking, or then it increased.
Okay. And on a scale of 0 to 10, 10 being the worst, how would you give?
Sorry, I cannot hear.
Regarding the severity of the pain, 10 being 0 being the least and 10 being the worst, how much would you give?
Around 4 to 5.
Is there any particular time the pain gets worse?
No particular time.
Okay, so you also have difficulty in breathing, is that right?
Yes.
So is that associated with your chest pain?
I think so. It's associated with pain.
Do you cough?
Yes, little bit, not for a long time. Just
any blood in when you cough?
no blood.
And then did you notice swelling around your legs?
No swelling.
How many pillows do you have to use or when you sleep lying down?
Only single pillow.
Yeah. And that how have you ever woken up gasping for air at night?
No, I don't know. I cannot even walking up from.
Okay. Do you have any indigestion?
No.
Any heartburn?
No heartburn.
Any gastritis? Like something when you burp in your mouth? Acid taste? Okay.
No.
So is there any particular disease for which you are seeing the GP?
Okay, I have some COPD diagnosis and hypertension, and some heart disease also. My disease said that.
Okay, so any particular drugs you are taking right now?
I take some drug, like maybe a lot of train, but I cannot remember.
Okay, so do you remember the dose?
No.
Dose of the warfarin? No. How long have you been taking warfarin?
Around 5 months.
And do you know why you are taking warfarin?
Maybe due to my heart problem.
Okay. Any allergies?
No, I have no allergy.
Any allergy to medication?
No, I have no allergy to medication.
Have you undergone any surgeries before?
Yes, I have surgery 4 weeks back, and I have a hip surgery. My leg is maybe replaced or something, they say.
For which leg? Left or right?
Right leg.
Right leg. And now you also mentioned that cramping pain. Is that on your right or left leg?
It's mainly right leg.
Right leg. And the chest pain is on your left?
Yes.
Okay. And then is there any family history who has the similar problem? Okay.
No.
Can you present your history now?
Okay, I just did a history taking for a 50-year-old man who presented with chest pain for 4 weeks, which is sudden onset stabbing pain on the left side of his chest, which is getting worse day by day. And he also complained of cramping pain in his right leg, associated with dyspnea for which has been over 4 weeks, but no signs of heart failure. Other signs of gastric problems such as PUD also excluded. So
what are your differential diagnosis for this patient?
According to the fact that he's on warfarin, my provisional diagnosis is pulmonary embolism. I also consider myocardial infarct, pneumonia, pericarditis, and peptic ulcer disease, or pancreatitis
How would you confirm your diagnosis?
by doing the physical examination and doing the blood tests such as a full blood count UNA, liver function test, renal function test, and also chest X-ray, ECG, echocardiogram if necessary, ACT-PA to exclude pulmonary embolism.
What are the treatment alternatives that you can offer to the patient?
For the pulmonary embolism, for my disease stable patient, it will be normal heparin therapeutic dose. For unstable patients, unfractionated heparin infusion or catheter-directed thrombolysis. For surgical options, it will be embolectomy.
Okay. What if patient only has COPD, acute exacerbation of COPD or asthma? How would you manage the patient then?
I will give inhalers steroids.
Okay, good. What have you missed?
I missed from past family history and the rest.
Yeah, and you even forgot to mention it with me as well, that if time would have allowed you, how would you have covered your, or how would you have, yeah.
I think I was focusing more on the pain details.
Yeah, but the time was not enough. But then you should have known that what parts of history taking were supposed to be covered. So at the end, you could have said that if time would have allowed me, I would have asked all the and then ICE also ID expectation and concern. That is also very important, other than the family history and social history and past. Past, I think you asked, but not the remaining. Okay, good.
And I have a query.
Yes, please.
Here the two pain like cup pain and also chest pain. So we go 10 questions for every pain, or how we can manage the time? I was confused.
Cough pain. Cough is a symptom associated with the chest pain. Once you ask for the cough, then she asked reasonable questions, that is the cough associated with sputum or with blood? Have you ever coughed out blood or anything? So it would not take 10 questions, but the relevant that you rule out if patient is throwing out blood as well. So you can maybe think of tuberculosis or malignancy. So you'll ask other related questions with that. If you are losing weight, unintentional weight loss or anything, or any other associated symptoms. So you have to manage the time and you have to ask adequate questions.
Oh, okay, ma'am. Thank you, ma'am.
Thank you.
Yeah, I forgot to ask malignancy.
Yeah, to rule out malignancy.
Yeah.
Started your timer and here is your question. Right, so if you have read and understood considering the clinical examination situation, kindly begin.
Will enter the room, wash my hands, greet the patient. Hello, I'm Dr. Muhammad Arab, surgical doctor. They have been asked to examine your cranial nerve, which is the nerve that supplies your face and your neck. Are you okay with that?
Yes. Yes.
Thank you. May I confirm your name and age, please?
Nova, 23 years old.
Okay. I'll start by, okay. Do you have any problem with smelling?
No.
Like any only beside the patient, I will ask him to close one of his nostril and smell, okay, and do for other one. Okay,
Yes.
then I would like to examine his optic nerve. I would
Yes.
like to start by the visual acuity by Snelling chart 6 meters from the eye of the patient. Can you read these letters for me and close one of your eyes?
Okay.
I will do the same for the other eyes. Now I would like to do the confrontation test. I will ask the patient to close one of her eyes and just with my fingers, okay, looking for the visual fields, and do for the other eyes. Then I would like to examine his accommodation reflex. Can you just focus on one point towards the wall?
Okay.
Now I would ask the patient to look at my finger just close to his nose, looking for any convergence or divergence of his eyes. Then I would like to examine his pupils. First with light reflex, looking for direct and consensual like reflex, and also light to light reflexes. Then I would like to examine by doing fundoscopy, looking for the red reflex, and also examine his macula. Okay. After that, I would like to examine the color vision. Then I would like to examine his movement, examine his oculomotor trochlea and abducent. Can you follow my finger with your eyes? Okay, in H shape. I'm looking for any lateral gaze defect. After that, I would like to examine his trigeminal nerve. Start by the touch sensations by any cotton beside the patient. Do you feel this touch? And ask the patient to close his eyes. Then I would like to examine this pinprick, the pinprick test by any pinprick beside the patient. Then examine his ask for mastication muscles. Ask the patient to clench his teeth, looking for any occipital and temporal muscles. Okay, I would like to examine his facial nerve. Can you close your eyes? I will try to resist this opening of the eyes. Can you raise your eyebrows? And then examine his, any test sensation in tongue. And I would also like to examine to tense his cervical muscles and ask the patient to smile. Okay. Then I would like to examine his vestibulocochlear nerve. I would like to do 3 tests, use whispering test. I will ask the patient to close one of his ear and do whispering test. Then I would like to do the Weber and the Ryan test by turning fork. The Ryan test, I will start by turning fork, putting in his mastoid bone. Can you hear this vibrations? Tell me when it's stopped. Then I will assess his air conductions. Then I would like to examine the Weber test by putting in the vertex of the patient's skull, looking for any conduction deafness. After that, I would like to do the otoscopy to examine his ear. Okay, if it is the right ear, then I will grab the otoscope with my right hand, just like a pencil clench. Hello?
Yes.
Yes. After that, I would like to examine the left ear as well, and then do the march on spot. I will ask the patient to stand and close his eyes, and then march on spot, just like he's walking. And then I will assess the glossopharyngeal nerve. can you open your mouth and say, then I would like the patient to drink a sip of water. Okay, after that, I would like to assess the vagus nerve and the accessory nerve. I would like the patient to shrug his shoulder and also resist steering to the left side or right side, assessing for sternocleidomastoid. Then for the hypoglossal nerve, I'd like the patient to bring out or stick out his tongue and movement of his tongue.
Okay, can you summarize your examination now, please?
Yes, they have examined 23 years old girl who has RTA. On the examine his cranial nerve, always normal except the vestibulocochlear nerve when there is conduction deafness, bone conductive deafness. Also, when examined by heteroscope, there is hemotympanum, and all other cranial nerve is normal.
So what are your, okay, how would you confirm hemotympanum? How would you interpret that?
By first examine her ear by otoscopy.
Yes.
And then I'd like to ask for CT brain and also audiogram and ENT review.
According to your examination, patient has what type of hearing loss?
Conductive hearing loss.
And hemotympanum is secondary to basal skull fracture, maybe. Okay.
Most likely due to basal skull fracture.
Yes. So what was the result of the cranial nerve examination that you did? Vestibular, cochlear, and facial.
Yes, there is a vestibulocochlear nerve injury.
Okay. What are the management options that you can offer to the patient?
As this patient has RTA, I would like to manage this patient in a TLS protocol,
Okay.
securing his airway, cervical collar, and also adequate breathing and circulation. Then I would like to involve ENT, CT brain, and also audiogram.
Audiogram, yeah, and ENT review. Okay, good. But yeah, good. Nice. Thank you. Can you tell me, yes,
Thank you.
can you tell me what you see here? Would you be able
Yes,
to?
this is tympanic membrane showing the hamulus and also the tense flaccid and tense flaccid tensile and
Okay.
there is the embo at the center,
Cone of light is
and also there is
where?
the cone of light.
Yes, where? At what location?
Yes, cone of light for the patient at the level of 7 o'clock.
Yeah.
So this is left ear.
Left ear. Good, thank you. Yes, Dr.